When people think about depression, they think about mood. They think about sadness, loss of interest, poor sleep, maybe hopelessness, but they rarely think about constipation. But clinically, that could be a mistake because constipation can give us a clue towards the most serious forms of depression, particularly melancholic depression and at times psychotic depression. The gut slows, the body slows, thinking slows, the drive slows. And once you start noticing that pattern, your whole understanding of depression becomes sharper. I'm Dr. Sanil Rege, consultant psychiatrist and educator. One of the most useful shifts in clinical practice is recognizing that depression is not just something people feel. It is something that can affect the whole system. People often do not walk in and say, "I'm depressed." They say, "I feel heavy, I feel stuck, I can't get going, my body feels shut down." And sometimes, especially as a clinician working on the medical wards, referrals don't often come with low mood. They come with, "I haven't opened my bowels properly in days." The medication chart shows 3 different laxatives. No change in bowel movements. So in this video, I want to explore why constipation can be an important clinical clue in depression, especially in melancholic and psychotic states. How it links to gut-brain biology, autonomic function, inflammation, dopamine and noradrenaline, and why paying attention to it can help with both diagnosis and monitoring response. So let's start off from the patient perspective, the lived experience. This matters because the symptom often arrives as part of the broader experience. The patient feels slowed, flat, foggy, physically heavy. Appetite is down. Movements reduced. Speech is punctuated with ums and ahs. Thinking is slow. And alongside that, bowel function often slows as well. That is clinically relevant. In practice, constipation can easily be attributed to lifestyle, diet, hydration, inactivity, or medication side effects, and that's correct. But sometimes that framing is too narrow. And this matters particularly in psychiatry, because in melancholic depression and psychotic depression, what you're seeing may be a more general slowing across the entire organism. Cognition is slowed, activity slowed, physiological rhythms can be slow. This is why we often see low blood pressure. So why does this happen? You see, the gut is deeply connected to the brain through multiple pathways. There is autonomic regulation, there is the enteric nervous system activity, there is immune signaling, and there are hormonal influences. And there are brain systems involved in salience, motor output, effort, arousal, and behavioral initiation. You see, dopamine as a neurotransmitter plays an important role in gut motility. So let's think about how we can use this clinically. Firstly, in melancholic depression and psychotic depression, these are 2 of the most severe forms of depression. Here, patients may not complain of low mood, but what is observed is psychomotor changes and neurovegetative changes. Changes in sleep, changes in appetite, weight loss, and either increased activity or decreased activity. They can present with psychomotor retardation, slowing, or psychomotor agitation. Family members may say their personalities changed. Patients describe themselves as not being able to engage in activities and derive any pleasure from it. In psychotic depression, this pattern becomes even more magnified. Here, the patient may be fearful, burdened by guilt, barely eating, barely moving, and significantly shut down. What we know as part of clinical literature is that in psychotic depression, constipation can be one of the most common symptoms. And the patient complaining of constipation is sometimes attributed to major depressive disorder with somatic anxiety. That's a mistake, because the key question to ask about constipation is not just about how often they're going to the toilet or emptying their bowels, but rather, are they worried about constipation? Because what happens in melancholic depression and psychotic depression, the thought pattern changes. The thought is no longer just a worry. It's moved towards becoming a rumination or an overvalued ideation. And in psychotic depression, the overvalued ideation moves towards becoming a delusion. So let me explain the difference between ruminations and delusions. Ruminations and overvalued ideations occur in melancholic depression and are lower down the hierarchy, but are very serious. Here, ruminations and overvalued ideations occupy a significant component of the person's mind. So when I ask a question, what proportion of the day do you spend thinking about these thoughts or the concerns that you have constipation? The answers might be all the time, 12 hours of the waking day, or when I wake up, the bucket's full of these thoughts. This tells me that the thoughts have become all-consuming, indicating a higher salience and the individual moving closer towards severe rumination and prodromal psychotic depression. This matters because treatments differ. These two forms of depression do not respond to SSRIs or SNRIs because they often need a low-dose antipsychotic medication, particularly psychotic depression. Another reason this symptom matters is that bowel function can sometimes improve as the depression begins to biologically lift. Patients may not initially say my mood is better, but they might say it feels like I have that little bit extra energy. I'm moving more. And unless we ask, they don't tell us about the bowel movements. I ask them, is the intensity of the thoughts related to constipation reducing? In other words, is there more space for other thoughts, other activities? And usually, with improvement, the intensity drops. That tells me that they're actually improving in their treatment trajectory. Because often recovery in depression is seen in function, rhythm, movement, and bodily regulation before the patient can fully describe emotional change. In fact, often the emotional change and the cognitive change occurs towards the end. So the core features of melancholic depression in terms of thoughts, which are obsessional guilt, somatic ruminations, financial ruminations, and nihilistic ruminations, reduce over time, and they're often last to reduce. So bowel function can be one of the small clues that tell us that a shift is occurring. This is where I'd like to cover the depressive subtypes because they become clinically important. Now, I've covered depression as a heterogeneous entity in this video here. The key point is that not all depressions present the same way. Some patients present with more anxiety, affective instability, and interpersonal sensitivity. That's a different form of depression. Others, as we're talking about here, present with marked psychomotor slowing, low drive, anhedonia, amotivation, and bodily shutdown. With this pattern that I've mentioned, dopamine and noradrenaline become especially relevant to our thinking. So in melancholic depression and psychotic depression, evidence tells us that frontostriatal circuits are significantly affected. And we know frontostriatal circuits depend heavily on dopaminergic modulation. In fact, dopamine constitutes 80% of the catecholamine content in the brain, and dopamine gets converted to noradrenaline. So I want to keep this nuance. So depression, we're not reducing it to one neurotransmitter, but systems that are involved in activation, effort, movement, salience, and behavioral activation matter here. And when those systems are underactive, both mood, activity, cognition, and gut motility can be affected because dopamine plays an important part in gut motility. Then there's the wider system story. We think about inflammation as well, and autonomic dysregulation, both of which can influence gut motility. The burden of medications at the same time also should be taken into account. So a heavy burden of anticholinergic medications can contribute to constipation. So by the time constipation shows up in a depressed patient, you may be looking at the downstream expression of several interacting processes rather than one simple cause. So although we can prescribe laxatives and think about lifestyle and exercise and diet, it's important to recognize that constipation may be signaling something really important. And that's why it deserves a lot more respect clinically. So the practical message that I want to highlight is simple. If there's one thing to remember, it's that if you're assessing depression, ask about bowel function, especially because it can provide clues towards melancholic and psychotic depression. And here what's important is that there are two aspects. One is the intensity of constipation as a worry occupying the person's mind, and two, the actual motility. Both need to be taken into account. And when constipation is associated with psychomotor change, appetite change, diurnal variation, cognitive slowing, energy, drive, autonomic symptoms, sleep, and movement, then we start building a broader picture. I'm Dr. Sanil Rege, and you're watching the Dr. Rege channel. If you liked the video, hit the like button and let me know in the comment section your thoughts on this curious symptom in depression. I look forward to seeing you in the next video. Until then, stay curious. Bye-bye.